So I am Stephanie Kroeze. I'm a radiation oncologist and I work in a university hospital in Zurich in Switzerland. Yeah, so if you look at Psma Pet Staging, you see that there are some false positives, especially with the fluoride PET. So what you see there is that in the ribs especially, but also in the pelvic area, that you have up to 40 to 60% of false positives, meaning you have an uptake, but it's not really a metastatic lesion. This is different compared to the gallium PET. There you have a very high sensitivity, meaning that if you see something in the PET, it is also most likely to be a metastatic lesion. There is a difference, especially in uptake and what you see and where you see it. So for PET scanning for prostate cancer, you have different tracers. So you have, for example, the choline PET, the PSMA PET, the fluoride, and you can also have different traces for the PSMA. Now, if you look at the choline PET, there you see that if the PSA level is higher than 2 nanograms per milliliter, then you are most likely to see everything. But if it's below that level, then you might miss some lesions that you can't see with your PSMA PET. Now, with the PSMA PET, it can be that if you have the gallium, you see a lot of lesions in the bone. But you have trouble looking at the local recurrence because the tracer also goes into the urine, so everything is lighting up there. And there you might have difficulty seeing it there. That's a difference to the fluoride PSMA tracer, where you don't see the urine as much, so that's better than to look at your local recurrences. On the other hand, you have these own specific bone uptakes there. So these are the differences between the tracers. Yeah, so at the moment we don't have any prospective trials looking at this, so we don't have this data yet. What we do know is also from prospective studies that if you have an oligometastatic disease, meaning a low tumor burden, in the synchronous metastatic setting, that if you treat the prostate with a focal treatment, so radiotherapy, next to the systemic therapy, that these patients will have a better prognosis. So this means that in this situation, a local treatment next to the systemic treatment is helpful. We don't know at the moment if you should also treat the oligometastatic lesions themselves as well. So we are waiting for the data for that. There are several trials looking at it, but we don't know yet. There are some retrospective studies that do say that these patients might benefit from this. Yeah, so SUV max is a good example of a parameter for PET scanning. We do know that this is higher in high-grade tumors and higher Gleason tumors, but we don't really know what the effect of the treatment is on these patients. Now, since we don't have this prospective data yet on treating these oligometastatic lesions at all, it is kind of unfair to say that if you have a higher SUV uptake now, that you already exclude these patients from this treatment. So at the moment we actually don't know if this is a useful parameter in the treatment of oligometastatic disease. So this is an important one, and we should study this in prospective studies to actually look at it, the effects, yes. And so Psa Kinetics is another factor that you can use to look at prognosis and at the treatment effect. This is mainly in the metachronous situation, so after you already treated the primary and there is a recurrence. There we know that if the PSA velocity is higher, so if you have a very short doubling time, 3 months, 6 months, that these patients have a worse prognosis. And for these patients you might be able to say that a local treatment of these lesions might not be very beneficial. But here again, we are lacking the data, so we don't really know if this is the case. So I think that you can treat these patients, but you have to be aware that this is a more aggressive situation if they have a very short doubling time, and you have to be aware that they can metastasize again, and maybe that you need a double systemic therapy there. In these cases, I think you mean in the synchronous oligometastatic situation. Actually, there is no place for FDG PET in this situation at all. FDG PET, you can use it, especially for some aggressive prostate cancers where you don't see a PSMA uptake. You might be able to see an FDG uptake. But these are usually tumors that are very aggressive. And what we are trying to treat here are these patients that have only a limited number of lesions and might have a better prognosis. So this is probably not the group where you are going to look for with an FDG PET. So for this group of patients, it doesn't play a role yet, or not at all. Yeah.